Hi, this is Peter Glenn Y. Chua, and this is the third part of the first lecture on antibacterial agents for YL6 of the Ateneo de Manila University, the School of Medicine and Public Health. For this part, we will be discussing translation inhibitors. When we talk about translation inhibitors, we are talking about translation in the sense that we are converting nucleic acid information into proteins or another type of nucleic acid. But particularly for antibiotics, we are targeting the ribosome or the ribosomal RNA. And based on this diagram, you can see there are six main categories, although you will encounter other categories as you go through the other lectures. And these six will be our coverage for this part. These will be lincosamides, streptogramins, the drug chloramphenicol, the drug class macrolides, oxazolidinones, and the drug class of tetracyclines. And we start with the last in this particular diagram, the class of tetracyclines. Tetracyclines are translation inhibitors in the effect that they inhibit the smaller subunit of the bacterial RNA. So, an important characteristic of tetracyclines is that they cross the placenta and the blood-brain barrier, the intact blood-brain barrier. So in the absence of inflammation, these tetracyclines can cross and treat central nervous system infections. Um, an important consideration for tetracyclines, since these drugs are given orally, is that you should not give these together with dairy products. In fact, you should not give them at all with any preparation that have a good amount of um, 2 plus cation molecules. 2 plus cation charged ions would include your calcium, magnesium, iron, F2, the ferrous, not the ferric, the ferrous, strontium, and aluminum. Why? Um, because these ions are effectively prevent the absorption of tetracycline by the body. So, for tetracyclines to work, they need to cross the cell membrane of bacteria and enter the bacterial cell where they can interact with the bacterial ribosome. And so, one of the defenses of bacterial cells is the action of efflux or efflux pumps. In a simpler sense, you could say the bacterial cell is vomiting out the tetracycline. And the efflux pumps are one of the mechanisms of bacterial resistance against tetracyclines. You will see that tetracyclines are based in our slide are released or excreted by the body through the liver and the kidneys. Note the exception for tigecycline and doxycycline that are primarily excreted through the bile. So tetracyclines are very useful since they are able to treat a lot of those atypical bacteria. Atypical in a sense that they are not straightforward gram negatives or gram positives, but rather they have unique characteristics that are difficult to treat for your other drug classes. Meaning, these bacteria have particular niches in the body. For example, your chlamydia, your mycoplasma, your rickettsia, which are really, really small bacteria. And And tetracyclines are also notable for being prophylaxis for certain diseases, including leptospirosis and the bubonic plague. Tetracyclines are extended spectrum or broad spectrum antibiotics, depending on the variety. They have action against both gram-positive and gram-negative bacteria. Although I emphasize resistance is a growing problem. Minocycline is useful for treating the meningococcal carrier state because, as we've mentioned earlier, the tetracycline is able to cross the blood-brain barrier even in the absence of inflammation. Tigecycline is notable for being useful against MRSA and VRSA and streptococci and actively growing mycobacteria, in other words, tuberculosis. Note that on the lower right portion of the slide, you will see a comparison of the absorption of different tetracyclines. And you will see that minocycline and doxycycline are very well absorbed through the oral route, while tigecycline is poorly absorbed through the oral route and is thus um, mainly used parenterally, meaning intravenously or intramuscularly. The molecule of tetracyclines is highly reactive to divalent or 2 plus cations. And because of that, um, bones that are, since bones are um, mainly cement made of calcium and magnesium and protein um, and polysaccharides, um, tetracyclines interact or bind to the calcium. And if the tissue is still being formed, tetracyclines can actually cause deformities. They can weaken the structure. And so, with um, treatment of young children with tetracyclines, we can expect some fluorescence, meaning the teeth are quite translucent, or if they are exposed to UV light, they actually emit a particular glow because the nucleic acid within the teeth are able to bend the light more actively compared to teeth that is impregnated more completely with calcium. So we also see some discoloration and some enamel dysplasia. Children under 8 years of age, meaning children who haven't yet fully formed their bones, are when they are exposed to tetracyclines are particularly susceptible. As with many strong antibiotics that have an extended spectrum, we expect a certain alteration of the normal flora. We have tackled earlier the issue of Clostridium difficile colitis, and a similar event can happen with the use of tetracyclines. Since tetracyclines and antibiotics in general are not very selective when it comes to friendly or normal flora and pathogenic flora, all bacteria that are susceptible are killed. And so there is an imbalance of bacteria, be it in the gut, in the vagina, in the mouth, in the skin. And the alteration of the native mucosa flora opens the surface, opens the cavity to overpopulation of pathogenic bacteria. The overpopulation itself, or the disproportion of the population spread, is in itself the disease. So we can see some itching, some inflammation, some proliferation of fungi that would otherwise be controlled by other bacteria. We also see some administration related effects. This is not specific to tetracycline, but this is more related to, how the drugs are given through intravenous methods, through the mouth, or through intramuscular route. And then we also see some photosensitization, vestibular reactions as can be expected from a drug that is has a particular affinity for salt ions, divalent salt ions, and we can also see tetracycline to have some impact on the metabolism, particularly renal tubular acidosis. Again, because of the molecules' interaction with divalent cations, they sway the movement of salt of divalent cations to a certain side, and therefore they do not really cross the magnesium, the calcium. They do not cross membranes quite easily because they are bound to tetracycline. So we move on to this slide wherein we see a comparison of the different antibiotics and how they interact with the 50S and the 30S subunit of the prokaryotic ribosome. We see that the erythromycin, a macrolide, clindamycin, a lincosamide, and the drug chloramphenicol occupy a space in the 50S that is quite overlapping. What does this mean then? This means that these drugs would have a similar effect on the metabolism of bacteria because the space that they target is overlapping or close together. And it also means that giving these drugs in tandem may not have a collaborative or a synergistic effect. These drugs are redundant to each other, meaning you don't give erythromycin in tandem with clindamycin or with chloramphenicol because these drugs target the same site or the O and O overlapping sites on the same molecule. So that is something for you to consider when you are giving antibiotics in tandem. On the other hand, you will see there are antibiotic regimens that include one cell wall disruptor, so it could be a penicillin, and one translation inhibitor, it could be a macrolide. Those are rational combinations because they have different mechanisms of action. We have a bacteriostatic and bactericidal molecules. But on that note, remember that there is some synergy and some competition or some um, non um, incompatibility between bacteriostatic and bactericidal antibiotics. But let's park that. And let's move on to the next drug class, which is of macrolides. Macrolides are one of the most popular drugs for the past few months since azithromycin, one prime example of a macrolide, is being used very heavily for the treatment of pneumonia. Macrolides have a common nucleus, which is the macrocyclic lactone ring. One part, one good uh, thing about macrolides is that they are quite they are available in different preparations. There are oral macrolides, azithromycin, for example, can be given through the mouth. It can also be given intravenously. Um, and you also have topical forms of macrolides that you can use as drops for the ear or for the eyes. So, since macrolides are translation inhibitors, they require access to the cytoplasm, to the internal cellular environment of bacteria. And the main mechanism of bacterial resistance is through efflux pumps, or in other words, the bacteria vomits out the macrolide. And then we also have this enzyme called esterase. Just like your beta lactamases, these esterases destroy the macrocyclic lactone ring, which is the backbone of your macrolides, and effectively destroying the molecule. There is also some modification of the backbone by bacterial methylases, which makes the molecule bit larger or wonkier in shape, in the sense that the drug will not be able to access the site within the bacterial ribosome. As with your tetracyclines, macrolides can cross the placenta, but it cannot cross the blood-brain barrier. Therefore, it is not a good drug choice for treating meningitis. But what is more attractive for macrolides is that it can enter polymorphonuclear leukocytes and macrophages, meaning abscesses, purulent spaces within solid organs. Macrolides are your bet. So, for example, you see, let's say, a cystic lesion in the liver. Oh, that looks like a cyst, an amoebic cyst that is, filled with cellular debris, and it looks like it is quite inflamed. You could, you would probably treat it for the amoebic infection, but you should also consider treating it for a bacterial infection as well. Um, Macrolides are mainly excreted through the liver, but note the exception of clarithromycin and its active metabolite, which are cleared by your kidneys. Now, macrolides are P450 inhibitors. What does that mean? This means that there are drugs that are considered um, more effective when the P450 is inhibited. So, if if the macrolide is given, therefore you expect theophylline, anticoagulants like um, salicylic acid, steroid like methylprednisolone to be more effective. Meaning a smaller dose would have a greater, longer impact. So consider that when you are giving antibiotics. This is an important drug interaction because P450 inhibitors, cytochromes, are in the neutralization of your drugs, and they function in the excretion and the metabolism of your drugs. And if the metabolizing enzyme or the metabolizing molecule is inhibited, you expect the drugs to remain in circulation longer and cause the effect correspondingly. So, since macrolides are excreted through the liver, metabolites of macrolides can cause cholestatic hepatitis, especially if um, they form crystals, and especially if um, um, the juices or the excretions of the liver are a bit more sluggish or sludgy, then you could expect some cholestasis happening. So macrolides are quite useful as treatment for infections, specifically for the lungs, because they treat a wide variety of bacteria that cause lung infections. Corynebacteria, bacteria, chlamydia, legionella, listeria, gonococci. So these are some of the more common atypical bacteria that cause lung infections. Um, in fact, based on our established guidelines, the front line would be coamoxiclav. In the absence, or if coamoxiclav is not useful for the reasons of allergies or some other reason, then you could consider the use of azithromycin or clarithromycin as a frontline treatment for pneumonia. Note that these drugs would have variations in the way they are metabolized by the body. Clarithromycin are metabolized by the liver but cleared by the kidney. Azithromycin is primarily by the liver, and telithromycin is excreted by both liver and the kidneys. Note that clarithromycin is actually being used to treat Toxoplasma gondii. Toxoplasma gondii, you would be familiar or you may have heard of this, in that they can actually cause a form of blindness in children if the child is exposed in utero. Toxoplasma gondii is not a bacterial organism. It is a protozoal organism. But why is it being treated with clarithromycin, an antibacterial? Remember that your protozoal cells, even human cells, have um, mitochondria, and mitochondrial RNA, your mitochondria have their own RNA, is prokaryotic in structure. So, in effect, clarithromycin shuts down the energy infrastructure of a protozoan. And by effect, it is inhibiting the growth of your Toxoplasma gondii because there is insufficient energy to support the Toxoplasma from movement, support the Toxoplasma from to grow. And so we move on to this slide wherein we see certain cases of staphylococcal infection. Um, when you see um, golden crusting, when you see purulent um, papules or purulent swellings, um, a fluctuant mass with a punctum, those are words that you would associate with a staphylococcal skin infection. A staphylococcal skin infection would manifest as a pimple, tagihawat, a boil or a pigsa, a furuncle. It could also manifest as scalded skin syndrome in children, especially among infants that are wearing diapers. Um, and it could get worse in that staphylococci can enter the bloodstream and cause osteomyelitis, meaning a bone infection, cause meningitis, an inflammation of the meninges, of the lining of the central nervous system, and as we've passed earlier, pulmonary abscesses. And staphylococci, although by itself do not produce, a specific toxin like you would have Clostridium tetani producing that tetanus toxin, the bacterial cell itself is quite um, irritating. So you do have a toxic shock syndrome. It is the debris of your staphylococci that triggers the body to respond, and the body responds uh, similar to the way it responds to shock. In a way, the body interprets the bacterial debris as, oh, we are overwhelmed with bacteria and we need to be a bit more aggressive in controlling this. So we see a shift in fluid, and you see in hemodynamic instability, as we see toxic shock. um, But that happens in certain circumstances, especially when staphylococci have created a biofilm. So you see that in tampons or in bandages that have been left in place and not removed, um, uh, pessaries, yun, mga um, surgical procedures done in the abdomen or in the genital areas. So, what are the drugs that you can use to treat staphylococcal infection, or maybe as a prophylaxis to prevent staphylococcal infection? You will remember cloxacillin, which is an isoxazoline penicillin, orally administered. You could also give cephalexin or a similar first generation cephalosporin. Another drug would be vancomycin. And then you would encounter these drugs that are a bit stronger but are frequently used to treat staphylococcal infections. You would see tetracyclines, Cotrimoxazole, which is a combination of trimethoprim and sulfamethoxazole, that's TMP-SMX. You could also use linezolid, daptomycin, and fifth generation cephalosporin like ceftaroline. Staphylococcal infections are very common. You will see this in the community, and you will see this especially during the summertime when water access can be problematic and people are not able to take a bath as regularly as they should. Staphylococci tend to stick to hairs, so therefore, um, when you're going to treat a person or a child for pimples, boils, furuncles, make sure that you also apply some topical antibiotics inside the nostrils for 5 to 7 days, 2 to 3 times a day, because that is one of the sites that uh, staphylococci like to hide in, inside the nose. And so we move on to the next drug group, lincosamides, another type of translation inhibitor drugs. A leading example would be your clindamycin, a very popular drug used to treat skin infections. But much consideration is requested if you're going to use this drug. It is quite easy to access, and it's quite useful because it's a the spectrum of clindamycin is quite wide. I mean, it's used for anaerobic infections, so uh, parapharyngeal infections, deep neck infections, oral dental infections are treated commonly with clindamycin, since clindamycin is also available as an oral preparation in form of capsules. But the ease of access to clindamycin threatens the relevance of clindamycin in the future because resistance is growing. But as it is, clindamycin is very useful as an antibiotic. It is able to control the growth of streptococci, staphylococci, and as I've said, anaerobes, including protozoans like pneumocystis and toxoplasma. It is not suitable for enterococci and gram-negative aerobic bacteria. So clindamycin for gram positives. It is also known to cause Clostridium difficile colitis, and it is metabolized by both the liver and the kidneys. Our next drug is chloramphenicol, which is quite useful for treating meningitis. Um, because it can cross the blood-brain barrier. It can be used to treat rickettsial infections. Rickettsia are notoriously small bacteria, and so they penetrate, the blood-brain barrier quite easily. And this particular drug has been quite notorious for certain adverse reactions. And the adverse reactions have been named quite memorably. Um, Being an old drug, chloramphenicol is an old drug, meaning it's one of the first drugs to be discovered and commercially made available. Some notable adverse reactions are aplastic anemia, bone marrow suppression, and the gray baby syndrome. So, if you see a red man, it's more probably due to vancomycin. But if you see a gray baby, it's probably due to chloramphenicol. And the fact that chloramphenicol causes these symptoms against hematopoiesis, because it creates some problem in the formation of your red blood cells, it should not discourage you from prescribing it for certain indications like for eye infections or ear infections, especially if the patient is already of age. So maybe not for children, not for infants, not for pregnant women, but you can give it to school age children, to adults, and it's still considered as an essential drug by the WHO. And it is, note please, it's a P450 inhibitor, meaning certain drugs are made more potent by chloramphenicol. So, some of the more recent drugs, but less accessible, are your streptogramins, of which there are mainly two, quinopristine and dafopristine. So, there are certain bacteria that are quite difficult to treat. Enterococcus faecium, for example, is quite difficult to treat because of certain resistances. Much like your MRSA, methicillin, and vancomycin, Enterococcus faecium is quite difficult to treat. And so, quinopristine and dafopristine have been developed to treat um, these infections, among others. But it is also quite useful to treat streptococci, staphylococci, and pneumococci. This drug, these drugs are administered intravenously. And as you can see in this diagram, um, much like you don't give clarithromycin, chloramphenicol, and and clindamycin in combination, consider that these drugs also have overlapping active sites uh, with other translation inhibitors like your macrolides and your um, aminoglycosides. Oxazolidinones, a leading example would be your linezolid, is a very, very useful antibiotic. It is a reserved drug based on the WHO essential medicines list. It is able to treat multi-drug resistant staphylococci, vancomycin resistant enterococci, gram-positive rods, and mycobacterial tuberculosis. So, linezolid has a very, very impressive coverage, but it is not suitable for gram-negative bacteria. If as treonam is also quite useful for gram negatives, linezolid is only for gram positives. Note that your linezolid is a known monoamine oxidase inhibitor, meaning if you take certain drugs, like your monoamine oxidase inhibitors, there are certain drugs that are used for psychiatric purposes, there may be some synergistic effects. Your linezolid is metabolized by the liver and excreted through urine. The most important thing for linezolid really is the fact that it can treat multi-drug resistant staphylococci, meaning this is a reserve drug, a very good drug against multi-drug resistant bacteria. And then you have fusidic acid. Um, by this point, I think you have the idea that Staphylococcus aureus is quite a pesky bacteria in that it is ubiquitous. You see it everywhere and it is difficult to treat because of so many resistances. There is increasing interest in developing fusidic acid into a parenteral preparation because currently fusidic acid or fusidate is mainly used as a topical antibiotic. But fusidic acid is now being considered as an option for treating staphylococci, multi-drug resistant staphylococci, um, staphylococcal infections. And fusidic acid preparations containing fusidic acid can now be administered parenterally. Although I I am not aware of any preparation currently available in the Philippines. It is metabolized by the liver and excreted in bile. Oh, fusidic acid, notice the structure is a steroid. So it is it is easy for fusidic acid to cross the fatty cell wall and enter your bacterial cell. And so we come to the last few slides of this third part. We see here a good summary of different translation um, inhibitors and the different sites of action they have in the bacterial cell. For today, for this lecture, notice that we did not discuss all of the drug classes here. We discussed inhibitors of cell wall synthesis, your peptidoglycan synthesis inhibitors, your glycopeptides. We discussed the various penicillins, cephalosporins, um, carbapenems, and monobactams. We discussed tetracyclines. We did not cover aminoglycosides. That's for the next lecture. We did pass by molecules that target the 50S subunit of the bacterial ribosome. There are other drug classes that we did not tackle. These would include your sulfonamides, fluoroquinolones, your metronidazole is a very useful drug, and of course rifampicin, which is used for the treatment of tuberculosis. So that's all for the next lecture, which will be delivered by Dr. Jun Cuenca. This is another table that summarizes different molecules, different antibiotics, and you can use this as a reference as you familiarize yourselves with the different antibiotics, the same list, an extension of the same list. All right. Oh, and a good reference for understanding the utility of antibiotics would be to check the essential medicine list from the WHO. This particular excerpt is from the 20th edition, although we already have the 21st edition from 2019. So, what I like about this is that it's quite short, but this listing for this edition doesn't do justice to the different molecules. You will see that in the 21st edition, there's a more thorough description of the different antibiotics. You will see preparations and the dosages and the indications of each molecule listed here. But the key point for understanding the modulus of essential medicine is that there are three main categories. You have your key access antibiotics, your watch group antibiotics, and your reserve group antibiotics. Meaning your key access are used as frontline for many bacterial infections. Your watch group antibiotics are used for particular indications if your access group are not available or is not safe for the patient. And your reserve group is, as labeled, reserved as the last resort when alternatives have failed. And please remember these molecules that are in the reserve group, these are not prescribed left and right. In fact, for you to use these molecules, in many hospitals, you will require the approval of the Infectious Disease Control Committee or of an antimicrobial resistance committee in the health facility, because the use of these antibiotics must be very carefully considered. So these would include aztreonam, fourth generation cephalosporins, fifth generation cephalosporins, polymyxins, which include polymyxin B and colistin, fosfomycin, oxazolidinos, linezolid, tigecycline, and daptomycin. So these drugs require approval of oversight committees and are not prescribed routinely in the clinics, are not prescribed routinely in the primary care setting. These are used mainly in the hospital setting. All right. So this is the overview of the different topics that we've covered for this part of the for this and the last part of the first lecture. All right. So thank you very much for your attention. These are some of the references I use, and thank you. That's it.